It is a real pleasure and an honor for me to present to your group today. I hope that next time I speak to your group, it can be in person instead of virtually. I'd also like to thank Bear for sponsoring this program. What I would like to do today is to understand the importance of CKD blood pressure management, to review the benefits of lowering controlling blood pressure in CKD patients, to review antihypertensive therapy for CKD patients, discuss some new progress in clinical research in CKD blood pressure management, and finally, to discuss the choice of antihypertensive drugs for CKD patients. This next slide shows how the definition of hypertension in the United States has changed over the past 50 years, where the initial definition in 1980 was hypertension was defined as a blood pressure of greater than 160/90, and that has gradually decreased up until today, where hypertension is now defined as a blood pressure greater than 130/80. So next, I'd like to review the studies that have looked at blood pressure in patients with chronic kidney disease. This first slide shows trials in which only a subset of participants had chronic kidney disease. And although these studies were quite large, you can see with only a few exceptions, the percentage of patients with chronic kidney disease, defined as an eGFR of less than 60 mLs per minute, was relatively low. And you can see that in terms of mortality in CKD patients, none of them were statistically significant. And in terms of renal outcome in CKD patients, none of these were statistically significant either. So next we can look at trials that were conducted only in patients who have chronic kidney disease. And again, that you can see that these were relatively small trials compared to the studies in the last slide. And regardless of the definitions that were used, again, there was no difference in mortality and no difference in CKD outcomes. And finally, there were several trials that once the randomized part of the study had concluded, there was extended observational follow-up. And you can see that even in these trials, there was some benefits in terms of mortality in the ASK trial from 2017 and the MDRD trial from 2017, and also just barely reaching significance in one of these three trials in terms of CKD outcome. So when we have situations where individual trials are too small in terms of sample size, we then turn to meta-analyses, and I'm going to review a couple of meta-analyses. This first one, published in 2017, was a review of over 4,000 articles, and through a process resulted in 18 studies that were included in the meta-analysis, which included just under 16,000 participants who had hypertension, an eGFR less than 60 mLs per minute, who were randomized to either an intensive or less intensive blood pressure lowering regimen. So this slide shows the individual studies. It shows whether the individual study favored either more or less intensive blood pressure control and the p-value. What I would like you to focus on is the very bottom of the slide, which is the summary of all of these 18 studies. And you can see that here we have a total of over almost 16,000 patients, and there was a benefit of lowering blood pressure, and that was statistically significant based on the p-value. And this is a slide that looks at specific subgroups for these trials. And what I've highlighted here with the red arrows is that you can see that you were more likely to have a benefit if the achieved blood pressure was less than 125 millimeters of mercury. And you were most likely to achieve a benefit if the difference between the two groups was equal to or greater than 12 millimeters of mercury. So this is the second meta-analysis trial that I would like to present. And again, this was comparing all-cause mortality targeting a blood pressure of less than 130 versus a standard of less than 140. What is different about this meta-analysis is it includes individual patient data, not pooled data, but individual patient data from these 4 trials, which were combined together, which gave us just about 5,000 chronic kidney disease patients. So this is the consort diagram, which explains what was done. So they looked at the NIDDK and National Heart, Lung, and Blood Institute repositories. They had identified a total of 16,000 patients, of which 11,000 did not have CKD. So we have about 5,000 patients where we had the primary outcome of mortality. And then we had a slightly smaller group, about 4,000 patients, who had secondary outcomes that were able to be evaluated. So here we can see on the left-hand side, we had a total of about 4,500 patients which all-cause mortality could be evaluated, and a little under 4,000 patients where we could look at either cardiovascular mortality or cardiovascular composite outcome. So this slide shows you the outcomes for those studies for this individual data meta-analysis. And you can see that for the primary outcome, that there was a benefit in terms of decrease in mortality with a p-value of less than 0.05. And that in terms of the secondary outcome, in terms of the cardiovascular outcome, that it just barely misses being statistically significant with hazard ratios of about 0.8 for both of these outcomes. So now that I've reviewed the benefits of lowering blood pressure in patients with chronic kidney disease, I'm now going to talk first about the proper measurement of blood pressure, and then review the KDOQI US commentary on the 2017 hypertension guidelines, which will include non-pharmacologic interventions, the blood pressure goal, as well as pharmacologic therapy. So as we go through these recommendations, it's important to realize that all of these guideline statements are rated based on both the strength of the recommendation and the quality of the evidence. So here we have the ratings for the strength of the recommendations, which goes from 1 to 3, from strong to moderate to weak. We also have a recommendation that is of no benefit, and also a recommendation that is strong. And then for the quality of evidence, we have A, B, and C, with A being strong, B being moderate, and C being limited or expert opinion. So now I'm going to review the technique for accurate blood pressure measurement. And one thing to keep in mind is that this is not only something that is beneficial in the clinic setting, but also beneficial for patients to measure blood pressure at home. And certainly, I find it much more helpful to have my patients measure blood pressure at home, keep a diary, and bring this in when they come to see me in the clinic. I'll let you translate that first. So the first step is to properly prepare the patient. What's very important is that the patient should be sitting in a chair, feet on the floor, back supported, for at least 5 minutes before the blood pressure reading is taken. They should try and avoid caffeine, exercise, or smoking for at least 30 minutes before the measurement. Their bladder is empty. They should not be excited during this time. They should not talk. They should not watch things on their smartphone or TV that might get them upset. It's important that the cuff is not placed over clothing, but on the bare arm. And it's important to realize that if a patient is sitting or lying on an exam table, that is not proper positioning of the patient. So the proper technique for blood pressure measurement, you want a blood pressure device that has been validated and is calibrated on a regular basis. The patient's arm should be supported, such as on a desk. The middle of the cuff on the patient's upper arm should be at the level of the right atrium, which is also the midpoint of the sternum. It's very important that you use a correct cuff size. The bladder of the cuff should encircle about 80% of the arm. And you should note whether or not you had needed to use a larger or smaller than normal cuff when you record the blood pressure. And you can use either side of the stethoscope, the diaphragm or the bell, for auscultatory readings. So to take the proper measurements, the first visit, it's recommended that you record blood pressure in both arms, and that you should use the arm that gives a higher reading for all subsequent readings. if you're going to repeat blood pressure measurements, you should separate each of the measurements by 1 to 2 minutes. If you're listening to estimate the blood pressure, you want to use a palpated estimate of the radial pulse to estimate systolic blood pressure. And you need to inflate the cuff 20 to 30 millimeters above this level for an appropriate reading. And then again, if you're listening to obtain the blood pressure, you want to deflate the cuff pressure about 2 millimeters per second, and then listen for the appropriate sounds. So in order to properly document the accurate blood pressure readings, not only do you record the systolic and the diastolic, but if you're using the auscultatory technique, the systolic pressure is the onset of the first Korsakoff sound, and the diastolic blood pressure is the disappearance of all the Korsakoff sounds. And that you should record those using the nearest even number. You should also note the time of the most recent blood pressure medication that was taken before the measurement. And then finally, you want to average the readings over a number of different clinic visits or a number of different measurements that the patient has taken. You really shouldn't rely on just one reading, but use the average of 2 or more readings obtained on 2 or more occasions to estimate the individual patient's level of blood pressure control. And it's also important to provide the blood pressure readings to the patient, both verbally and in writing. So one of the questions that I have been asked quite a bit is, this takes really a long time to do. This is hard to do in the clinic. Can I just use some sort of correction factor that I can apply so I have a sprint blood pressure? So to answer that question, this was a study that was just published online last month. And what was done was they compared sprint trial measured blood pressures in individual participants with blood pressure that was measured in the same individual in the electronic health record. So they had over 3,000 patients who had at least 3 outpatient blood pressure readings and at least 3 readings from the sprint trial. It turned out that the median number of electronic blood pressure measurements was 17, and the median number of sprint blood pressure measurements was 16. So you can see this is quite a robust data set to make this comparison. So in answer to the question, is there an adjustment factor that you can use? And the answer is no. Here is the data, and this is a Bland-Altman plot. So here you have the mean systolic blood pressure measured in the intensive arm of sprint, the mean systolic blood pressure in the standard arm of sprint. And here is the difference between the electronic health record blood pressure versus the trial blood pressure. And you can see that there's a big spread. Sometimes the electronic health record blood pressures are higher than the sprint measurements. Sometimes they're lower than the sprint measurement. The bottom line is really that there is a lot of variability here. And that variability means that you can't just adjust, that you have to measure blood pressure properly, because you can't apply a common correction factor to approximate research quality blood pressure measurements. So now let's talk about non-pharmacologic interventions to manage hypertension. So the recommendations here are to lose weight if you're overweight or obese. This is a strong recommendation. To eat a heart-healthy diet, such as the dietary approach to stop hypertension, the DASH diet, to reach a desirable weight. Again, a very strong recommendation. However, the caveat here is that this diet should not be used on people on dialysis and may need to be modified in advanced chronic kidney disease due to the risk of hyperkalemia. And then finally, to do at least 2 hours and 30 minutes of moderate exercise per week, such as brisk walking. It's okay to break this up into 30-minute intervals. Next is, who is treatment of high blood pressure recommended for? So we can talk about patients who blood pressure control is a secondary prevention, who have already had a cardiac event. And here we can see that the target is less than 130/80 for both United States and for China. For primary prevention, that is a 10-year risk of a cardiovascular event is 10% or greater. And here you need to understand that those who have clinical heart disease, those who have diabetes, or those who have chronic kidney disease are automatically considered high risk. If the patient does not have any of these three conditions, then you can estimate their risk using an online calculator. And again, this is strong evidence for systolic blood pressure. Again, less than 130/80 in both the United States and China. And then primary prevention for those who have a 10-year risk of cardiovascular disease less than 10%. The recommended target is less than 140/90, both in the United States and in China. So, the guidelines were based on a fair amount based on the SPRINT study. And for those of you who are not familiar with SPRINT, I just wanted to go ahead and review the SPRINT trial and how it was designed. So it was to examine the effect of a more intensive high blood pressure treatment. So patients were randomized to either a systolic blood pressure goal of less than 120 versus a blood pressure goal of less than 140 in the standard arm. The primary outcome was a combination of myocardial infarction, acute coronary syndrome, stroke, congestive heart failure, and cardiovascular death. To be included in SPRINT, you needed to be at least 50 years old, you had to have hypertension, and you had to have at least one additional cardiovascular risk factor, which would include clinical or subclinical cardiovascular disease, chronic kidney disease, EGFR between 20 and 59, a Framingham risk score for 10-year cardiovascular disease of 15% or greater, or an age of 75 or greater. I wanted to review the SPRINT findings for patients who had chronic kidney disease. What we can see here is that these were relatively older individuals with an average age of 72. Almost 50% had an age of 75 or greater. About 40% were women. The mean serum creatinine level was 1.43. The mean EGFR was just under 50 mLs per minute. And as you can see, there were minimal amounts of proteinuria. And these two groups were virtually identical between the intensive arm and the standard arm. So this is the Kaplan-Meier curve for the primary cardiovascular outcome. And the broken line is the intensive arm. The solid line is the standard arm. This is the cumulative risk of having the primary cardiovascular outcome. And you can see that this just misses being statistically significant with a hazard ratio of 0.8. If we look at the Kaplan-Meier curve for all-cause death, again with the hazard ratio here, the broken line being the intensive arm and the solid line being the standard arm, we can see that this was statistically significant, that there was a decreased risk of death in CKD patients who are in the intensive arm, and the hazard ratio was 0.72, a 28% reduction in all-cause mortality. And then this is the Kaplan-Meier curve for the main kidney outcome. And the main kidney outcome was a decrease in EGFR greater than 50% from baseline, which was confirmed by repeat testing 90 days or later. And you can see that there was no difference in the marked decline in EGFR. The hazard ratio was 0.9, and it did not reach statistical significance. Therefore, there was no harm in terms of the main kidney outcome in SPRINT. Now let's go ahead and talk about medication choices to treat blood pressure. So first, it's important to realize what is not recommended, and what is felt to be potentially harmful is the simultaneous use of an ACE inhibitor, an ARB, or a renin inhibitor. In terms of first-line agents to start, the recommended agents include thiazide diuretics, calcium channel blockers, ACE inhibitors, or ARBs. So strong recommendation. Beta blockers are not considered first-line therapy unless the patient has ischemic heart disease. And the reason for that is beta blockers are now considered significantly less effective for cardiovascular disease and stroke protection compared to diuretics or calcium channel blockers. So let's talk specifically about hypertension treatment in patients with chronic kidney disease. So in those who have CKD stage 1 or 2, who also have proteinuria, defined as an albumin, urine albumin level of 300 milligrams per day or greater, an ACE inhibitor is considered reasonable to slow the rate of kidney disease with a 2A recommendation, and an ARB is felt to be reasonable if an ACE inhibitor is not tolerated with a 2B recommendation, the difference being the strength of the evidence between ACEs and ARBs. In those who have CKD stage 3 through 5, again, regardless of the level of urine protein, an ACE is considered reasonable to slow the rate with that same 2A rating, and ARBs may be reasonable if an ACE is not tolerated, again, a 2B rating, with the difference being the strength of the evidence. So in summary, the strength of the evidence is moderate for ACE inhibitors, but it's weak for ARBs, regardless of the stage of chronic kidney disease. So which drugs should be used for the treatment of hypertension? You need to consider several different etiologies, including age, concurrent medications, out-of-pocket costs, comorbid conditions, including gout, diabetes, and chronic kidney disease, and a history of drug tolerance. It's important to avoid using 2 or more drugs from the same class to treat hypertension, with the exception of diuretics that have different mechanisms of action. So now let's talk about treatment implications of chronic kidney disease patients with hypertension. And in these series of slides, what I'll do is I'll have the United States recommendations, and I'll also, if it's available, provide the Chinese recommendations. So the US recommendations recommend a blood pressure goal of less than 130/80, strong recommendation, with the exception for prior stroke being a target blood pressure of less than 140. Some things to consider is that there's limited data in CKD stage 4 to support this blood pressure goal of less than 130 millimeters of mercury. And in stage 5, there really are no large randomized clinical trials on blood pressure goals. And this blood pressure goal is not applicable to patients with stage 5 CKD. The Chinese guidelines recommend that in CKD patients who have a urine albumin excretion of less than 30 milligrams per 24 hours, the goal blood pressure is less than 140/90. If the albumin level is greater than 30 milligrams per 24 hours, then the goal is less than 130/80. So next, we can talk about diuretic use in chronic kidney disease. And the first comment is that thiazide should not automatically be stopped when the eGFR is less than 30, because there have been shown to be some benefits with an eGFR in the 20 to 30 range. However, you need to be aware that there are some side effects of thiazide diuretics, including hypokalemia and hyponatremia, particularly among the elderly, as well as hyperuricemia. The recommendation is to check electrolyte levels and eGFR within 4 weeks of initiating a thiazide, and then after each increase in the thiazide dose. In terms of the choice of diuretics, chlorthalidone is recommended compared to hydrochlorothiazide. Chlorthalidone has been used in many major blood pressure trials, and specifically in more advanced chronic kidney disease. You should also remember, though, that if the goal of the diuretics is diuresis rather than blood pressure control, maximum diuretic effects are seen when a thiazide diuretic is combined with a loop diuretic. And in all cases, you need to follow potassium levels closely. So next, we can talk about treatment of hypertension in special populations, the first being renal transplant. And the recommendations here are a goal blood pressure of less than 130/80. And it's recommended that a calcium antagonist be used on the basis of improved GFR and kidney survival. And the note about calcium channel blockers is that it helps counteract vasoconstriction of calcineurin inhibitors, and therefore are first-line therapy in transplant patients. But you need to use them with caution because there is some drug-drug interactions with immunosuppressive agents. So next, we can talk about the diabetics. Here, the guidelines are consistent between the US and the Chinese guidelines, with a goal blood pressure of less than 130/80. All first-line classes of antihypertensive agents are useful and effective, and that ACEs or ARBs can be considered in the presence of albumin. So some of you may be familiar with the ACCORD trial, and I wanted to review this because the original data from the ACCORD trial, it was a blood pressure trial in patients who had diabetes. So unlike the SPRINT trial, which just looked at blood pressure, the ACCORD trial looked at both blood pressure as well as blood glucose levels. So when you do this, when you have two different interventions, it's called a 2x2 factorial design. And in this design, it's assumed that one intervention, say the blood glucose intervention, does not affect the results of the other intervention, the blood pressure intervention. Was this assumption true? So here is the flow for the ACCORD trial. So 4,700 patients were randomized to either an intensive blood pressure goal or a standard blood pressure goal. And then for each of the blood pressure goals, patients were randomized to either a low hemoglobin A1C level or a higher hemoglobin A1C level. The initial findings of the ACCORD trial was the intensive blood pressure control strategy did not significantly reduce the primary cardiovascular outcome. So the question is, why is SPRINT results different than ACCORD results? So here is the primary outcome. You can see that there was a modest benefit in the intensive arm versus the standard arm, but this was not statistically significant. So what about the glycemia arm? There was a higher mortality in the intensive glycemia arm, which led to the discontinuation of therapy after 3.5 years. And there were more deaths in the high glycemia arm compared to the standard glycemia arm that was statistically significant. So intensive therapy to target normal hemoglobin levels increased mortality and did not significantly reduce major cardiovascular events. And this showed a previously unrecognized harm of intensive glucose lowering. So what if we separate the ACCORD trial, so we look at the standard glycemic arm separately from the intensive glycemic arm? And when we do, we can see that the SPRINT results are virtually identical to the results for blood pressure if you just look at the standard glycemic arm on its own. So the hazard ratio in SPRINT was 0.75. In ACCORD, in the standard glycemic arm, the hazard ratio for the primary cardiovascular event was 0.77. These patterns were similar for all-cause mortality. So the clinical implications of this reanalysis of the ACCORD data is that it supports the current guidelines of a systolic blood pressure goal of less than 130 in patients both with and without diabetes. So finally, we can talk about the elderly. The US guidelines recommend the goal of less than 130. The original Chinese guidelines had a more stepped approach in terms of controlling high blood pressure, but that has been changed with the revision of the Chinese guidelines. So I wanted to conclude my talk with reviewing the SPRINT results for participants greater than 75 years old. This was a group where the mean age was 80. And in this group, there was a significantly lower rate of primary composite outcome with a hazard ratio of 0.66, statistically significant, and a decrease in all-cause mortality with a hazard ratio of 0.67, and that the overall rate of serious adverse events was not different between the two treatment groups. So this slide is just a summary of what I have presented during this talk. I hope that you have a better understanding of how to manage blood pressure in patients with chronic kidney disease. So I'd like to thank you for your attention. Thank you very much for allowing me to present to your group. It's been a real honor and pleasure for me. And also thank you to my translator for her excellent work this evening.